Good morning, PT on Ice Daily Show. My name is Dr. Rachel Moore. I am super excited to be here with you guys this morning on the day after Christmas. I'm apologizing in advance for my congestion. I caught the flu right before Christmas, and I'm still kind of kicking up on the tail end of that. I am a teaching assistant for the Clinical Management of Fitness, Athlete, Pregnancy, and Postpartum Division, where we teach you guys how to work with pregnant women, keep them in the gym, get them back to the barbell postpartum. We have two offerings, a live 2-day course and an 8-week online course. Our first live online course of 2023 is coming up in Chicago on January 21st and 22nd. And the second live course is actually here in my town at my clinic, February 18th and 19th in the Woodlands, Texas. So hop into that. It's going to be super fun. Our first online cohort of 2023 begins on January 9th. So if you're looking to kickstart some 2023 with some CEUs, hop into that cohort. It's going to be great. And if you are looking to stay up to date on all things fitness for the pregnant and postpartum client, as well as pelvic health in general, head over to the resource tab on ptonice.com and sign up for our PPP on Ice newsletter. That is all of our announcements. So let's talk about what we're going to be chatting about today. Today, we're going to talk about breech babies. This is a topic that's pretty near and dear to my heart. I actually am 8 weeks postpartum with my second kiddo, and he was breech. And so when I first found out that he was breech, I kind of went into a tailspin and didn't know what my options were going to be. And it led me down a lot of research rabbit holes. And so today, I kind of want to bring you guys some of that information about a procedure that's not really talked about a whole lot unless you're in the trenches of figuring it out, and then delivery options for when baby is breech. So why do we as PTs need to understand the options for a woman with a breech baby? These women are probably going to be our patients. We may be seeing them for birth prep visits. We may be seeing them for pelvic floor issues in pregnancy. And we honestly may be one of the first people that find out that baby is breech. We tend to be one of the people that learn a lot in our sessions because we're one-on-one. We're spending a lot of time with these patients. And helping provide education about options can be really huge for these women, especially when we can give them pros and cons with evidence-informed backgrounds. A key role for us as physical therapists, I think we all can agree, is to come alongside our patients and support them through difficult decisions. And for some women, choosing to have a cesarean versus a vaginal delivery, if that's something that they had really had in their mind that they wanted to have, can be incredibly difficult. And so, us being there as a pillar of support and a pillar of support that is educated and offering research informed options can be incredibly helpful. So before we talk about those options, let's talk about breech positioning in general and then have just a quick history lesson. So breech means baby is in a head up, butt down position versus in a vaginal or normal vaginal delivery with a cephalic baby, that baby is head down, butt up. When baby's in a cephalic position, it's a easier, quote unquote, I use air quotes there, obviously, delivery because baby's head is the largest part of their body aside from their shoulders. So when head gets delivered, shoulders shimmy out and the rest of the body's delivered fairly easily. In a breech delivery, that's not quite the case. Sometimes it may be the feet that come out first, it may be the legs that come out first, it may be the butt that comes out first, depending on what type of breech the baby is. Breech positioning is actually fairly common prior to term. 1 in 4 babies are breech up to 28 weeks. And then as baby approaches that 32-week mark, they tend to drift and make their way head down in order to prepare for delivery. Even if baby is still breech after 32 weeks, they can still flip all the way up until labor. So there's all of this pressure to get baby to flip, when in reality, if baby is going to flip, there is a chance that they may do it after water breaks. In 2000, there was an international multi-center randomized controlled trial that was done called the Term Breech Study, and it compared planned cesarean delivery to planned vaginal delivery, short-term and long-term outcomes. The findings of the study really shook up breech delivery protocols. They basically found that perinatal and neonatal mortality, as well as serious neonatal morbidity, were less significant in the planned cesarean delivery, meaning planned cesarean deliveries were deemed safer than planned vaginal deliveries for women that were presenting with breech babies. Many influential groups, including the American College of Gynecology, took this and ran with it and adopted the policy that a planned cesarean delivery for a breech baby was the best option. For quite a while, things continued with this belief. However, this study has come under a lot of criticism for being skewed, and a lot of new research has come out that is leading us to pivot and help try to decrease the high cesarean rates that we have in the United States by training physicians in other techniques. Those two techniques, namely, are the ECV and vaginal breech deliveries. Sorry about my voice, guys. So, what is an ECV? An ECV is an external cephalic version. This is essentially a procedure that's done in a hospital with a provider manually providing resistance to a woman's abdomen to get baby to turn from a head up breech position into a head down cephalic position in order to have a vaginal delivery. This can be done with or without an epidural, although there are some studies that show that the ECV is upwards of 39% more likely to be successful if a woman has an epidural prior to the procedure. And this is because women are able to relax. This is not a comfortable procedure if you're having it done unmedicated because it is pressure on the abdomen and baby is rotating inside of the body. So when women are able to completely relax because of that epidural, they're not feeling that pain, only the pressure that tends to lend itself to higher success rates with the ECV. It's usually done with one or two practitioners, either one practitioner with hands on either side of the belly, or two practitioners, one with hands on one side, other with hands on the other side. It's done with ultrasound during the procedure to check in on baby, make sure baby's in an okay position, and monitoring of baby's heart rate to make sure that baby doesn't go under distress. This can be done preterm, before 36 weeks. This can be done at term, and this can also be done in labor if baby goes breech after water breaks and needs to be flipped back. We already mentioned that the epidural is one factor that can be done to have a higher success rate for the ECV. Some other things that can kind of play in there are going to be second and beyond pregnancies. So, women that have already been pregnant and already had a delivery because their uterus has already expanded and adapted to a baby tend to have higher success rates with this procedure. Baby's position, so being in what we call a flexed breech position where their chin is tucked and they're a little bit more curled versus extended. Placenta position being on the posterior side of the uterus. And interestingly enough, providers' skill and belief in the treatment. I think this is really interesting, especially being in the ICE world, because we know when we are providing musculoskeletal treatments that our belief in our treatment and what we feel about things like strength training and resiliency of our bodies is going to affect what the patient feels too. And I thought it was incredibly interesting that that carries over even into things like an ECV. The success rate of the ECV for women that are in their first pregnancy is about 33%. But when we get into second and beyond pregnancies, that goes all the way above 60%. So, two-thirds ish chance of having a successful ECV if you are in your second or beyond pregnancy. This is a procedure, and procedures are not without complication risk. The biggest complications that can happen here are a decrease in baby's heart rate, which is usually transient, a premature rupture of membranes, and uterine rupture leading to cesarean. I know those last two sound scary, but realistically, the risk factor or the amount of risk for that is only 0.5 to 1% of women that end up having an emergency cesarean following an ECV. So, why would somebody get an ECV? An ECV is done when somebody wants to try for or continue working towards having a vaginal delivery with a cephalic head down baby. If the ECV works and baby flips and baby stays, that's the route they go. If the ECV is unsuccessful, either baby does not flip at the time or baby flips and then goes back, we're then looking at two options. We can either have a cesarean delivery or a planned vaginal delivery. Most people assume that a breached presentation automatically means cesarean delivery, and that's really not the case. It is an incredibly common option for breech babies, namely in part to that study that I referenced earlier. And cesareans in general are incredibly common in the United States. They make up about 31% of deliveries, according to the CDC, but it is in the major abdominal surgery. And because of that, it's not without its own risks as well. Things like infection of wound site, dehiscence of wound site, plus the rehab factor of recovering from an abdominal surgery versus a vaginal delivery. Not that one is easier than the other, but they do have different factors on board. If someone is planning on having more children, having a cesarean, especially in a first delivery, may make it more difficult for them to find a provider who would then allow them to try for quote unquote a vaginal delivery. And it also may have some implications in uterine health. The term elective cesarean can be really difficult for some women, especially if having a vaginal delivery is something that they had really had their heart set on. And it sounds like they're choosing to have the cesarean when in reality, they're making the best case, quote unquote, decision for their situation. And that can be something that's hard to wrap your head around sometimes. And so that's where our skills as being a shoulder to lean on and a voice to listen to and somebody to kind of talk through things with as the therapist side of physical therapist can really come into play. Vaginal breech deliveries. This is, I would say, the most controversial of the three options: ECV, planned cesarean, planned vaginal delivery. This requires a provider that is trained and skilled in vaginal breech deliveries, and that is very difficult to find here in the United States these days. Some cities and some areas, it's a little bit easier. It's becoming more common now that people are kind of shying away from that term breech study decision, but it was a very difficult thing to find for a long time. If you go down the Google rabbit hole, much like everything else on Google, there are tons of websites and blogs that demonize vaginal breech delivery and says that it is absolutely unsafe. But it's not necessarily always the case. The American College of Gynecology even has a position statement on this now based on some retrospective studies that have been done. And we can understand and respect that these are only retrospective studies. These aren't randomized controlled trials, but it is something to help us kind of navigate our decision here. But these two reports noted that there was no perinatal mortality or morbidity in women who had planned vaginal breech deliveries when specific criteria was utilized. That criteria is that gestational age is greater than 37 weeks, baby's positioning. So either frank breech position, meaning they are in kind of, if you're watching live, like a little U shape. So legs are straight up, butt is closest to the birth canal, back is here. Or what we call a complete breech presentation, which is kind of like the fetal position just flipped upside down. So their knees are up to their chest, their butt is the closest thing to the birth canal. No fetal anomalies on ultrasound. So fetus, baby itself is healthy with no issues itself. And then this the size of mom's pelvis and the size of baby. And that's going to come into play here in a second when we talk about the risks. So I'll explain that a little bit more. So when we dive into risks, there are three big ones, two that are have implications for baby's health. So the first one is going to be a prolapsed cord. With a prolapsed cord, this means after water breaks and baby is starting to be delivered, the umbilical cord is delivered first prior to baby. In this situation, the cord can be pinched, which is then going to minimize the delivery of oxygen to baby in the birth canal. And depending on how long this goes on, that can be dangerous. Baby can also get stuck due to the proportion of body and head. Like we talked about earlier, when baby is delivered head down, head comes out, shoulders shimmy out, the rest of the body is delivered fairly easily. When baby is flipped, the largest part of their body, aside from their shoulders, is their head. And so as they're coming through that birth canal, they can get stuck in the pelvis. And if that happens, it becomes an emergency cesarean section. Babies who are born with a vaginal breech delivery also have a higher likelihood of a brachial plexus injury. This is typically a more hands-off delivery process where providers are trained to kind of take a step back and let baby deliver naturally. However, if baby does get stuck or is unable to pass on their own, then the use of forceps is heavily utilized in these procedures as kind of the go-to um, instrument or intervention that's used in order to assist baby. And when we use forceps, there are some implications for pelvic health healing for mom as well. There were 3 follow-up studies that were done to that term breech trial that looked at long-term outcomes for mom and babies, really looking at their morbidity and mortality, short-term and long-term. Now, while the term breach trial found that there were some short-term benefits or positives opting for the cesarean route versus the vaginal route, when they did these follow-up studies, what they found was that there was no long-term clear results, meaning that in the grand scheme of things, it didn't really significantly matter whether it was a prone vaginal delivery or a planned vaginal delivery or a planned cesarean delivery. So, all that to say, when we have a client coming in the door who has been told that her baby is breech, there are three main options here when it comes to delivery. They can have an ECV to try to get baby to be flipped into a head down position and move forward with a traditional vaginal delivery. They can have a planned cesarean delivery, or they can have a planned vaginal delivery. What decision they make is largely going to depend on mom's preferences and on the healthcare resources that are available to them. Especially in this situation, having trained providers, whether in the ECV route or the planned vaginal delivery route, are going to greatly impact the outcome of those decisions. I hope you guys learned something today. Like I said, when I was going through this journey, this was very overwhelming just knowing what these options were. And so, if we can provide counsel to even one patient to help them make this decision, it can be absolutely huge. I hope you guys have a fantastic Monday after Christmas. Hopefully, everybody is getting to continue some post holiday family time. Um, thank you guys for joining me today. Have a fantastic week.